I'm going to start the webinar right now. Good luck, everyone.
Thank you. All right, good evening, everybody. We're just waiting for a couple of folks to log on, and then we'll go ahead and get started. All right. All right, well, looks like folks are rolling in. Good evening, everybody. My name is Michael Awad. I'm one of the MIS and foregut surgeons at Washington University in St. Louis. And along with my co-host, Dr. Ivy Haskins, we'd love to welcome you to the 2024-2025 SAGES General Surgery Review. This is an annual event that we put on. This is actually our 9th year hosting it, and it's been a delight and honor to be able to bring this to you all. We've heard a lot of good feedback that this is one of favorite things every year in preparing for the ABSITE and other standardized questions. So we've got a wonderful program put together for you here with world-leading experts that are going to be ushering us through a series of rapid fire and high yield questions in a variety of topics. This session is recorded and will be made available later in the SAGES website for your review. And we will send out a link for where you can find that shortly. So I'm going to go ahead and bring up some slides here, and we will go ahead and dive in. Before we go into the specific topics, a couple things. Again, we've got a tremendous panel joining us today, and we will introduce each of them as their section comes up. Our overview for the program, and again with my co-host, Dr. Ivy Haskins, we will lead you through a series of, again, high-yield topics, first with esophagus, stomach, and obesity. And then after about half an hour, we'll pivot to general abdomen, hernia, and spleen, colorectal and anal disease. And finally, we'll wrap up on the topic of small intestine, biliary disease, and flexible endoscopy. The program is sponsored by SAGES, which I think many of you know, but SAGES is the Society for American Gastrointestinal Endoscopic Surgeons. It is a phenomenal organization that I've been privileged to be a member of for over 21 years now. Hard to believe, since I myself was a trainee, and have just been wonderful to be accepted into the family and the home that SAGES is, as part of my professional career, but also my personal development, and many tremendous friends and colleagues, several of whom are on the call today. SAGES envisions reimagining surgical care for a healthier world, and its mission is to innovate, educate, and collaborate to improve patient care. The values of the organization are inclusivity, innovation, service, excellence, global community, and of course, to have fun. And we're going to have a lot of fun tonight going over ABSITE questions. So I know you can't imagine yourself in any other place. I would also strongly encourage, for those of you on the call who are not yet SAGES members, to strongly consider becoming one. The benefits far outweigh any nominal cost of joining the membership. You get a significant discount to the annual meeting, huge access to professional development programs, educational offerings such as this and many others, a network across the world of colleagues and experts in our field. You get a subscription to the highly cited Surgical Endoscopy Journal, and members-only grants, career development awards numbering in the tens and hundreds of thousands of dollars, as well as an opportunity to make a difference and seek leadership opportunities. So there are a number of different membership categories, and the link to join is here, sages.org/membership. There are candidate members for those of you that are trainees, as well as medical student options. I also want to welcome you to join us in person at the 2025 SAGES meeting, which will be in sunny Long Beach, California. close to Los Angeles. This is going to be a phenomenal meeting that's shaping up to be, as you know, see the preview of the program. And the program chairs, Ann Lador and Mikey Jicky, have put together a tremendous program again this year. This is one of the highest yield meetings you'll attend every year. And again, please, love to see you in person there. Come up and say hi. Very inclusive and welcoming group. So pivoting to tonight's event. So this, we have heard a lot of feedback over the years and how important this is in helping to prepare for the American Board of Surgery in-service training exam, the ABSITE. This is the ABSITE content outline, and you'll see kind of here the weights of the various questions. This ABSITE, this webinar has actually become two parts because of its popularity and request for more and more topics. Tonight, we're going to cover the top half of the grid here. And then in a part two, which is in January 14 of 2025, we will cover the second half of the topics here. So you'll see, again, high yield preparation for the ABSITE, attending parts 1 and 2. The format, for those of you that are new to tonight's session, like I said, we're going to have a number of rapid fire multiple choice questions. And the questions, we will present the STEM with the answers. The panelist will read the question as well as the responses. We'll give about 20 seconds for people to digest the question. And then we will show the answer with a discussion of why the answer is correct, as well as why the other ones are incorrect. I also want to acknowledge and thank TrueLearn, which is our partner for the webinar tonight. TrueLearn, as many of you know, has a bank of high quality exam style practice questions, analytics, and you can customize and tailor your tests to help you prepare, not just for ABSITE, but for a number of other high stakes exams across a variety of fields. So a number of our trainees have already subscribed to this and really sing its praises. If you haven't already, please visit truelearn.com to check it out. And again, what we'll be displaying here this evening are actually the TrueLearn website. So with that in mind, I think we will go ahead and dive in. Our first presenter this evening is none other than the one and only Dr. Olivia Haney. Dr. Haney, welcome back again this year. She's based out in New York at Northwell Health. She is a bariatric surgeon, general surgeon, and robotic surgeon extraordinaire. And she's going to lead us in the topic of the first topic of esophagus, stomach, and obesity. Welcome, Dr. Haney. Thank you for being here. And I'm going to just give a second to pull up the slides while you are not here.
Thank you, Dr. Awad. I'm very happy to be back. I feel like that was a big introduction, and I hope that I live up to it for everyone. I wish that I was in Long Beach right now. It sounds a lot warmer than the cold, rainy New York City that we're in right now. But like Dr. Awad said, I do bariatrics general, a lot of robotics. And so the first stuff we're going to talk about is the top of the GI tract, esophagus, obesity related topics, which actually come up increasingly more on the ABSITE as it goes along and on your oral boards too. So we'll just go ahead and jump right in. So the first question is a 45-year-old female who presents with difficulty swallowing and frequent regurgitation of food. Manometry shows a peristalsis and impaired relaxation of the LES. Her contrast esophagram has a bird's beak appearance, and they want to know what the most durable non-surgical treatment for the palliation of dysphagia due to this condition is. Botulinum toxin, calcium channel blocker, pneumatic dilation, nitrates, or none of the above. So as you guys post your answers, I'm just going to give some test taking tips because I think that's something that's important. You always want to make sure you read the stem of the question really, really well. They're asking the non-surgical option. They're asking the most durable non-surgical option, not something that's going to last a little while and then get better. But which one of these is the most durable? So that's sort of what they're asking. And then obviously this is a two-part question, a secondary question, because they want you to know what the disease is and then how to treat it. So you have to know what that is. And then Dr. Awad, will you show the answers? Because I'm not seeing them yet.
Let's see. Do you see my screen with the stem and the
I see the
answers?
stem. Oh yeah, but I don't see I think last year I saw the people's answers. Is that?
Oh, that will be coming up in the
Oh,
Zoom
okay.
poll.
Okay.
Yes.
I was excited. All right.
Yes.
All right. So I guess we'll give you a couple of seconds here, but then we'll go ahead and get to the answer because this one's pretty straightforward. Oh, I click it. Do I click it?
No, that's okay.
Oh,
I will click it
sorry.
and that's all right. You know, I'll
It's
kind of
okay. I think I
walk
did
us
this
through
last
them.
year too. It's fine. Okay.
Yeah, there we go.
Perfect.
So
I love it.
the poll just came up, and so
Amazing.
we'll give folks an answer. So for those of you joining, should see a poll come up in your Zoom window, and you can choose answer A, B, C, D, or E corresponding to the answers here:
Perfect.
botulinum toxin, calcium channel blocker, pneumatic dilatation, long-acting nitrates, or none of the above. We'll just give it a few seconds.
Interesting seeing some different options here. This is why we do these.
Indeed.
Yes. All right. So
Okay, so yeah, we'll go ahead and show the explanation. Yeah.
all right. So the C's, got it
Hmm.
right here. The pneumatic dilation is the right answer. And the reason why is because of the stem, right? There are other ways you can treat this, and you can do Botox and you can do calcium channel blockers, but they're not the most durable option, non-surgical option for the palliation of dysphagia due to achalasia, right? Achalasia is what the first half of the question was asking you. And then it's asking you what that most durable non-surgical option is. So you can see here in the answers, which TrueLearn does do a good job about giving you the different rationales behind why the different answers are not correct. And you can see that Botox does help, but you can see it has a 25% chance of recurrence. And then same with our 25% chance of helping, and then 70% chance with the pneumatic dilation group. So really a huge benefit over the pneumatic dilation, and they're not asking anything about complications or anything like that. They just want to know what the most durable is. So as long as you know what the question is pointing you to, then you should be able to pretty easily get that one. Just don't get tripped up by the question stem. All right. So we're going to kind of keep on the same page here with esophagus with the second question. And this is a 75-year-old man who presents to your surgery clinic complaining of a few months history of worsening dysphagia, regurgitation of bland, undigested food, noisy gurgling, and halitosis. So already they're sort of asking you what this is, but then they tell you what it is. A barium esophagram shows a Zenker's. And then when considering the management of Zenker's, which of the following is true? So I liked this question. It's interesting because it does give you a lot of options here, but if you read through each one, even if you didn't know what a Zenker's was, I feel like you could answer it. So number A is a transoral endoscopic therapy using a rigid endoscope is the operative procedure of choice in all patients. Open technique for repair is only recommended in failed endoscopic approaches. A rigid endoscopic approach is more useful in patients with short necks and higher BMI. Flexible endoscopies prefer very rigid, and then a transoral approach with a rigid endoscope rather than an open diverticulectomy decreases the risk of mediastinitis. So we'll let you guys kind of take a think on this one and see what you come up with. But this is one of those questions you don't even really need the stem. It's just asking you a straightforward question. Which of the following is true about a Zenker's? So you have to think about the different approaches, surgical versus endoscopic, and then you have to think about what is true for this technique. Is it a rigid endoscope? Is it a flexible endoscope? And then when would you use each? And which of these, all four of these have incorrect things, and one of them has a correct thing. So
And Betty, did you pull the poll up already?
My apologies. Dr. Awad, would you like to pull up the poll? I think
Yes.
I'm having technical issues.
Oh, okay. Okay. That's right. We'll get the poll cleared and pulled up here shortly, but Olivia, we'll go ahead and move on to the discussion.
Perfect. So if you walk through all of these, you can see that this was the only really correct one, that a transoral approach with a rigid endoscope rather than an open diverticulectomy decreases the risk of mediastinitis. Yes, obviously that's true. When you do an open approach, you have a staple line in the neck. So that is a leak would increase your risk of mediastinitis. With a transoral approach, you do not have that. So that's why that's correct. It really has nothing to do with the Zenkers. It's just asking you about the different options. Like you actually didn't need to know when one was favored over the other. But the other answers are wrong. And you know that because the endoscopic approach is not the operative approach and choice for all patients, right? So actually in patients with a very large diverticulum, you want to do a surgical approach. And then if you have a very, very, very small diverticulum, you can actually just do a myotomy alone. So less than 2 centimeters. So this question is wordy, so I think that's why some people may get like tripped up on it, why there's only a 44% correct true learn response, because it really does take you to go through every single answer and see why what is wrong with it. So it's not just like a boom, you know the answer question. You have to read every question. So you just have to really focus on what they're asking you and understand why those answers are wrong. So this is a highly tested topic. Zenker diverticulum, it's not something that you see commonly in your residency probably, unless you're at like a high volume center for this. So, and the endoscopic approach probably not either. So it's something that you need to make sure you review before the test. Same with Acalasia. We talk about it a lot. It's very highly tested, but it's not something you see that commonly. So just keep that in mind as you're studying. All right, so question number 3. This is more of a straightforward question, so it should be pretty easy. It's just an anatomy question. So which of the following anatomic points of constriction represent the narrowest point of the esophagus? Now, this is like a you know it or don't question if you haven't looked this up or you don't know the answer. I mean, you can guess, but it's difficult, right, if you haven't like really studied this. So, and there are some of these questions on the AB site. It's like, boom, you move on and you're ready to go. So the cricopharyngeus muscle, the aortic arch, the left brainstem bronchus, the diaphragm, and the LES. So take a think on that. And I think they're going to pull the poll up for me, maybe, and we'll see how that
Sorry,
goes.
yeah, we're still working on that.
I don't know. It's okay. This
Poll.
one's.
Yeah, that's okay. Yeah, I think
Can I launch it? Can I see? Is that
oh,
working?
there we go. There we go.
Yes.
There we
Okay.
go.
All right. I pushed a button. I don't know. It's fine.
No, that's all right. It's coming up. And just while it
Okay.
is coming up, a couple of points. One, we do have the Q&A feature active in the Zoom. And so we, as panelists, will be monitoring that. So if there's questions that you have, we will do our best to try to get to it. We may not get to all of them, but we will attempt to do so. The chat feature is not active, but the Q&A is, so feel free to put your questions in there. And then one thing you'll notice with the responses, TrueLearn gives you the percent of folks who got certain questions right. On the right-hand side, it gives you an explanation of the rationale, the right answer, as well as the wrong answer, as well as key references and occasional images. So nice features. Thanks, Dr. Haney. Go ahead. We got our poll responses in.
Perfect. All right. So good job, everyone. A is the right answer. This is something that you just have to know, right? But if you think about it clinically, it can kind of figure it out, right? Where is it most likely to perforate if you're doing some sort of upper endoscopy? These are the 3 points. So there are 3 points here, the narrowest being the cricopharyngeus muscle. And then we've got the second point being the level of the aortic arch, and then the third area being the hiatus. So this is just one of those things you have to know, but it does make sense if you think about like the clinical implications of it. Not too much else to say on this one. Nice. All right. So again, this is a great question. I get so excited about these. 42-year-old woman with dysphagia over the past 3 weeks. It is thought that she might have an esophageal motility disorder. And what is the best test to evaluate esophageal motility? With this, you can either have the
Dr.
answers are
Haney, sorry, if you could read the response of the
yeah,
question.
sorry, sorry. A is endoscopy, B is esophageal pH probe, C is manometry, D chest x-ray, and E esophagram. So this is also one of those things where you can know it if you clinically think about it. You probably see this along the way when in your clinical duties. This one you guys should nail.
Good. And let's see if we can get that poll back up here. Okay, I know we've got, oh, there it goes. All right, go ahead and
Okay.
Fund.
All right, so we'll give you guys a second, but already you guys are crushing it. So we can probably move on. Great. So manometry, right? This is probably tested every year. It's the best test to diagnose and distinguish between the motility disorders. They'll sometimes even give you an image of manometry and have you kind of figure it out for the different types like Acalasia or just a peristalsis of the esophagus. But the other ones don't really tell you anything about motility. The only thing that people might, and I was going to say, yeah, esophagram would probably be the next best thing, right? But that's what might trip you up, but it's not the best test. So good job, everyone. All right, so the next question is, what is the major source of energy during the first 24 hours of starvation? A, protein, B, glycogen in the liver, C, fat, D, ketones, and E, glycogen in the muscles. This is another one of those things that maybe you read in your Pfizer book. And I think I can do the poll. Hold on. Yes. Okay. So take a second, think about it. It's a little tricky. It's one of those also you sort of have to know it questions. Test taking skills may point you in one direction, and we'll discuss that here in a second. But this is during the first 24 hours. So not like the immediate one that you get, but then sort of the second peak there. All right, good, everyone. That looks pretty good. I think we've got 100% of people here. That's good. All right, great. So good test taking skills, because B and E were like the best choices, right? Because you're like, oh, it's probably one of those. B, glycogen in the liver. And this is something you have to know, these metabolic phases for your app site. It's still tested there. Hepatic glycogen is the primary energy source in the first 24 hours of starvation. So this is during short periods of fasting. What happens is your insulin levels will drop, the glucagon will rise, and that mobilizes your hepatic glycogen, breaks it down to glucose, and that gets depleted very quickly. So that's why it's used within the first 24 hours. And then after that, it just tapers off. And then you start to use other types of stored energy sources like protein, fat degradation, and then glycogen in the muscles is also broken down later. So good job. And that's just another one of those you need to know, but you guys got it. So you're doing good. All right, the next one is another ABSITE favorite. 60-year-old man is evaluated for vague epigastric pain, dyspepsia, and anemia. Histology obtained by upper endoscopy shows lymphocytic infiltration of the lamina propria, forming lymphoepithelial lesions positive for CD20. What is the best initial treatment? So your options here are surgical resection, monoclonal antibody, C, chemotherapy and radiation, D, radiation, or E, antibiotics. So this is sort of like that first question we had where you have to know what it is. And then once you know what it is, you can answer the question. So I'll let you think about it for a little bit. They're giving you the CD20, they're giving you lymphocytic infiltration, they're giving you symptoms as well. And they're asking what the best initial treatment is. So, all right. A little bit of a split, but not too bad. Okay, so this is one of those MALT lymphomas. This is a very commonly asked ABSITE question as well. I think it's just easy for them to ask it because there's so many different iterations of it, but it can trip you up if you don't understand the treatment. So with any MALT lymphoma, if it's H. pylori positive, then you treat H. pylori first. There is a new from when I took the ABSITE, you test it for cytogenic analysis of the 11 and 18 type of H. pylori. And if that's positive, then you would also want to do radiation, especially if they do not respond to treatment. But honestly, this is sort of the classic question that they'll ask. They have a MALT OMA, you have H. pylori, you treat the H. pylori. Don't get crazy doing an chemotherapy, radiation, surgical resection, because it looks scary, but don't let it trip you up. You know what it is. And most of you guys got it, which is good. But this maltoma is very heavily tested on the ABSITE. So good job once again. All right. Our next question here is, A 51-year-old man on prednisone, 5 milligrams daily for rheumatoid arthritis, involved in an MVC, admitted to the ICU. Exploratory laparotomy is positive on a performed for a positive fast scan. The only intra-abdominal injury is a grade 2 liver injury managed with hepatography. CT scan demonstrates a T6 fracture. The patient is unable to move her lower extremities. He is fully awake and asking to be extubated, hemodynamically stable, hemoglobin 10.2, platelets 60, INR 1.2. Which of the following is the appropriate indication for stress ulcer prophylaxis in this patient? Great question. The answers are NPO status, platelet count, mechanical ventilation for 24 hours, traumatic spinal cord injury, and chronic steroid use. So this is one of those questions that I think a lot of people end up using stress ulcer prophylaxis maybe incorrectly in their day-to-day life. It's sort of just dogma that we treat everyone with stress ulcer prophylaxis, but there are actual indications for this. So go ahead and see what we got here. Nice. All right, so we'll show the explanation here. Perfect. So let's see, did we match up with the, yeah. Oh, no, okay. So D is actually the correct answer, even though I do think a lot of us think of mechanical ventilation. So this is actually something good to reiterate. The traumatic spinal cord injury requires stress ulcer prophylaxis with a PPI. The reasons for having it would be traumatic brain injury, traumatic spinal injury, and then coagulopathy, burns, which he didn't have any of that, right? That's why they're giving you his INR, his platelets, all of those things. But we know MPO status does not confer an additional risk. Mechanical ventilation, they're saying for at least 48 hours, right, predisposes you, but this is saying 24 hours, so that will trip you up a little bit. So if you look at this list, it's again asking sort of like, you know, what is the best answer? And traumatic spinal cord injury is one of those things that you should do every single time. So this will just give you a chance to take a look at that kind of dogma that you get in your training and just make sure that everything that you're learning for the ABSITE you've based on literature and that you're understanding why you're doing things. Nice. All right. A 65-year-old woman presents to the office 1 year after a laparoscopic Roux-en-Y gastric bypass with symptoms of fatigue, muscle weakness, difficulty sleeping. She fell recently and broke her arm. Which of the following vitamin and/or mineral deficiencies is most likely to be responsible for this presentation? Thiamine deficiency, hypocalcemia, vitamin C deficiency, iron deficiency, and vitamin D deficiency. Obviously, one of my favorite questions as a bariatric surgeon. Great question. This also is something that I ask my, medical students, residents, fellow in my office. Something you should know. Visit your bariatric surgeon's office hours and talk to their patients, see what vitamins they're on. These things you can kind of pick up along the way. I don't see let's see the poll here. All right. Oh, there it goes. Okay. We'll give you a quick second here. I only have a couple more, so we're getting through it. I can be talkative, but it's good. All right, good. That's pretty good. I love it. Good job. Vitamin D deficiency. So I always tell the residents in my office hours, like, vitamin D deficiency is also just like the most common vitamin deficiency in the general population. So that's a pretty good way to lean your hat on. But because you're bypassing that first portion of the small intestine, that's where the vitamin D is mainly absorbed. So almost every single one of my patients is vitamin D deficient. They all need to be supplemented. And the problems with it down the road are actually quite significant, especially in your female population for metabolic bone disease, osteoporosis, hypocalcemia, associated with vitamin D. So the other ones are much less likely, but you do want to be careful. Vitamin A, folate, iron, thiamine, we always supplement, B12, iron, and vitamin D. Those are sort of the big ones that you have to make sure you supplement. The other ones we'll check along the way to make sure, but this should be one of those like gimme questions. All right,
another. To interrupt, Dr. Haney, somebody in the audience has raised their hands. We're not going to be able to answer questions live, but please go ahead and type your questions in the Q&A, and we'll do our best to get to those. Thanks. Go ahead.
Okay, perfect. All right, so another great bariatric question. A 45-year-old man underwent an anti-colic Roux-en-Y gastric bypass several months ago and presents to the ER with cramping, abdominal pain, nausea, and vomiting. On exam, he has signs of involuntary guarding. He undergoes an emergency X-lab. Intraoperatively, the area of obstruction is visualized in the area between the mesentery of the jejunum and the transverse mesocolon. Which of the following could have presented this patient's bowel obstruction? A, performing a retrocolic retrogastric gastrojejunostomy. B, closure of the mesenteric defect at the jejunojejunectomy. C, closure of the mesenteric defect at Peterson's space. D, performing the GJ under less tension. And E, adding a sheet of chemically modified sugar molecules before closing. I like E. That seems fun. Don't pick E. All right. So this also kind of, you have to, I mean, this kind of gives you the answer here, but with an internal hernia, which is what they're describing, there's telling you what space it's in. So great job. Good job, everyone. You just had to know for this answer, what is the Peterson space, right? And we have a picture down here. If we scroll down to the bottom of this answer, keep going a little bit more. When you bring the anticolic limb over the transverse colon, there is a mesentery underneath that jejunum, and there's a mesentery where the transverse colon is. And that's the most common space for an internal hernia to happen. It is recommended that you close that space, but not all surgeons subscribe to that philosophy. So you may have some surgeons in your area that don't. And I mean, we get these all the time to come back, and typically you can do it laparoscopically, but sometimes it's very tight and you can't. One of the things that they do test on sometimes, as a little aside, is you want to start from the terminal ileum. If you start pulling that direction, you can typically get it to free. But if you start in a random spot in the middle, then sometimes you can actually make it tighter. So sometimes they will ask that, like, how would you start running the bowel? And that would be at the terminal ileum, because you're less likely to kind of tighten it as you go. But this is the Peterson space, classic. Even if in the question stem they said the surgeon had closed it, if the patients lose a significant amount of weight, the mesentery can reopen because of how like loose it is. There's not as much fatty tissue and the scarring can loosen. So don't let them throw you off. If that's the space, that's the space, even if it has been closed before. But good job on that one. So our next one is a 32-year-old woman with reflux disease, venous stasis ulcers, hypertension, hyperlipidemia, sleep apnea, and diabetes, presents to our bariatric surgery clinic for preoperative planning. She is interested in a gastric bypass and the effects on her comorbid conditions. Which of her listed conditions has the highest resolution rate after a laparoscopic Roux-en-Y gastric bypass? So she has many conditions: venous stasis ulcers, hypertension, hyperlipidemia, obstructive sleep apnea, and diabetes mellitus. And actually, when I took these questions, I got this one wrong. So this is you guys are probably all going to get it right, but it's interesting. This poor woman at 32 has the most comorbid conditions I've ever seen. So she definitely would benefit from a gastric bypass. Poor thing. Poor thing. We got to help her. And also sometimes they'll ask what surgery, and with this reflux disease as well, with her reflux and diabetes, a bypass is definitely her best option. So if they ask that, that would be a good secondary question. So, you guys nailed it. You're smarter than me. So diabetes is the most common resolved comorbidity here. Sleep apnea does get a lot better, like most of the time, but it's just difficult to prove that it gets better. I think patients don't follow up for sleep tests, so it actually isn't shown in the literature to be resolved as much as diabetes. And especially patients that have only had diabetes for a few years and they're not like maxed out on medical therapy, those patients have the highest rate of resolution for diabetes. So good job. I would have been in the D's here, but the E's have it, and that's right. And so just make sure that it's like you have to prove that it was resolved. But all of these things do get better. And with the bypass, the diabetes gets better most significantly. So nice.
We have time for one more question. I love the explanations here, though. It really gives a walkthrough of the surgery and everything. So, all right,
yeah, for sure. The TrueLearn explanations are so in depth too. So you can learn a lot just from reading those. All right. So 62-year-old male presents for follow-up after 2 years. After entrectomy, vagotomy, and B2 reconstruction for a gastric outlet obstruction caused by a peptic ulcer disease. He has been complaining of recurrent abdominal pain after eating. His basal acid output is 4.5 milliequivalents per hour. His resting gastrin level is 310, and his secretin test dropped his gastrin levels. Upper endoscopy with biopsy shows a marginal ulcer at the and antral mucosal. So what's the next best step in his management? So they have here A, H2 blocker, B, H. pylori treatment, C, CT scan with pancreatic protocol, D, somatostatin receptor scintigraphy, and then E, completion antrectomy. So they give you a whole bunch of words up here and numbers. They're saying, like, does he have a gastrinoma? And you have to figure out if that's true or not. But he doesn't, based on this history here. So they're kind of asking you, what's the reason why he has a marginal ulcer? And they're saying he has antral mucosa. So nice job. Completion antrectomy is definitely the answer there. The most common retained gastric antrum is probably the most common cause of marginal ulcer if they're not a smoker or do NSAIDs, especially with bariatric surgery as well. If you make your gastric pouch too large, then you can have recurrent marginal ulcers. But this question also points to like the gastrinoma. So the secretin test drops his gastrin level. So that's giving you that point. So you don't think that that's what's going on. But retained antrum's the answer, and you guys did a good job, but something just to think about with the gastrinoma. So yeah, good job, everyone. Really excited to see you guys excel and continue on down the body. As we said, we're going from top to bottom today. So enjoy.
Dr. Haney, thank you so much for a wonderful overview. Really appreciate your expertise and exam tips. And just a tremendous kickoff to the session this evening. So thank you. Now I'd like to welcome to the microphone, so to speak, my co-host, Dr. Ivy Haskins. Dr. Haskins, well known to many of you. It's a pleasure and honor to have her co-hosting with us tonight and in January. Dr. Haskins is Associate Professor of Surgery at University of Nebraska Medical Center and co-director of the Esophageal and Swallowing Center there. A tremendous educator in herself, and she's also co-director of the SAGES Fellows Career Development course, which hopefully many of you will have the opportunity to participate in. She ran a great program this year. Dr. Haskins, welcome, and she's going to introduce our next panelist.
Thank you, Mike, for having me. So we are going to be moving on to the general abdomen, hernia, and spleen questions, and it's my pleasure to introduce Dr. Awad's partner, Dr. Jeff Blatnik. I feel like your titles expand every time we talk. So he is an associate professor of surgery, newly the chief of the section of minimally invasive surgery. Congratulations. He's the co-director of the Hernia Center, and he's the associate program director for the general surgery residency at the University of Washington in St. Louis. He is a tremendous and wonderful teacher and colleague, and we're happy to have you again this year, Jeff.
Thanks for having me. This is such a great course. I think I say this every year. I really wish this was around when I took the ABSITE. I don't want to disclose how many years ago that was, but it was a while ago. But I think it's really helpful, and it's great to see all these kind of leaders in their areas of surgical specialties give you some more insight and stuff into it. And so we'll try to cover the hernia section, which is near and dear to my heart, as well as a couple spleen questions along the way. And for the sake of time, we'll just kind of jump right into everything. So our first question is, a 50-year-old man is scheduled to undergo an elective laparotomy for a distal pancreatectomy and splenectomy. Which laparotomy closure technique minimizes his risk of developing an incisional hernia? A running 2-0 polydioxanone or PDS suture taking 5 millimeter bites spaced 5 millimeters apart. A running 2-0 PDS suture taking 1 centimeter bites 1 centimeter apart. A running looped PDS taking 1 centimeter bites and 1 centimeter apart. Interrupted figure of 8 PDS suture with 1 centimeter bite spaced 1 centimeter apart. Or a running O PDS suture taking 1.5 centimeter bites spaced 1.5 centimeters apart. You know, and I think this is something that it's well published. It's not very well followed, probably in surgical practice along the way, but there is some actually really good data that shows what the best approach for this is. And I'm not sure if we're doing polls. There it is. Fortunately, they don't ask for different types of suture material. They keep it consistent. It's one type of suture material. That's PDS. That's a slowly resorbable suture. They give you different sizes, but I think the key here is the size of the suture and the size of the bites more than anything. Perfect. So this all relates back to what's called the Stitch trial. It came out in the Lancet in 2015. It's hard to believe it's been over 9 years ago. This is a very well done, double-blinded, multi-center, randomized controlled trial looking at all these different ways of closing fascia. I think most of us who are younger were taught kind of 1 centimeter bite, 1 centimeter travel, kind of big stitches. A lot of people still use looped PDS. There's no data to support any of that. The big concept here is small bite, small travel. That's what the Stitch trial looks at along the way. And so 2-0 suture, actually on a small needle, and 5 millimeter bite, 5 millimeter travel. I think the challenge clinically is you really have to think about it. Like it's actually pretty hard to do it clinically. But good job to the group. All right, next question. A 55-year-old man with a past medical history of end-stage renal failure, currently on peritoneal dialysis, presents for an elective open right-sided inguinal hernia repair. What is the next best step? So notice how that's underlined as we talk about test-taking strategies in managing this patient's renal failure in the immediate postoperative period. A, continue the patient on his peritoneal dialysis therapy. B, convert the patient to hemodialysis therapy. C, convert the patient to hemofiltration therapy. D, avoid peritoneal dialysis in the patient as long as possible postoperatively. And E, initiate medical management of the patient's renal failure for 1 week postoperatively. So again, the key thing here is next best step, not necessarily to say like one or the other is better or is not right. So as we kind of get the results trickling in here. Good, I think we're ready to show the answers. So good, the majority of you got it right. So actually you are okay to continue peritoneal dialysis in these patients. I think there's some subtle nuances. If you really ask a lot of the nephrologists about the volume of peritoneal dialysis they get and when they do it and that sort of stuff. But in general, most people would say it's safe to continue peritoneal dialysis for these patients. The next most common choice was actually B, convert the patient to hemodialysis therapy. That is not wrong. Like hemodialysis therapy would cover the patient, especially in regards to his renal therapy. But with an elective inguinal hernia repair, it's actually okay to continue the peritoneal dialysis, and you do not need to convert the patient to hemodialysis. So A is the right answer here. Next question. A 56-year-old man with significant cardiovascular comorbidities who weighs 80 kilograms or 176 pounds is undergoing an open inguinal hernia repair with local anesthesia. An ultrasound-guided peripheral nerve block is attempted medial to the anterior superior iliac spine with 10 mLs of 1% lidocaine with epi. The anesthetic is injected deep into the inguinal ligament and lateral to the femoral artery. Which of the following is the expected result of this attempted groin nerve block? So they tell you kind of where they inject it and what they're injecting. A, bowel puncture. B, paresthesias of the skin over the lower abdominal skin above the pubis. C, paresthesia of the skin over the medial thigh, root of the penis, and upper part of the scrotum. D, cardiac arrhythmia. Or E, impaired knee extension. So for this, you kind of got to know your anatomy, what's going on down there, where they're injecting. You know, is this the right spot? Is this where they should be injecting or not?
Some mixed responses on this
Yeah,
one.
this will be one worth discussing a little bit. Perfect. Yeah, let's show our explanations. So the correct answer is actually E, impaired knee extension. And so the concept here is they actually did not inject the correct spot. So an appropriate block would give you the correct answer of C, but they talk about here that the block was actually not in the right area. And as such, they actually called an inadvertent femoral nerve palsy. It's pretty rare, but it is a known complication of the block along the way, and it can occur when the injection is performed too deep or too inferior to the intended plane. So that's where reading the question where they talk about where they injected. So deep to the inguinal ligament is what's giving you in the wrong area. And that can result in leg weakness and particularly the inability to extend the knee. So some kind of tricky things there if you're not real familiar with how these blocks are done or the anatomy that's down there. This is another great one, whereas you're using TrueLearn to review the questions, they give you a really great example of where all the appropriate anatomy is and how to look at it. All right, let's move on. All right, we're going to start to get into some of these anatomy questions of inguinal and femoral hernias. These are things you really just got to know. They usually show up every year. So spend a little bit of time and go over the anatomy of everything along the way. So this question is asking about what the posterior boundary of the femoral canal is. Cooper's ligament, B, femoral vein, C, inguinal ligament, D, the lacunar ligament, or E, the transversalis fascia. The posterior boundary of the femoral canal. Yeah, thanks. I think the thing that always takes me a little bit of pause that I always have to think about when I read these questions is kind of how the anatomy is described versus how it is in the body. So posterior boundary, are they talking anterior, posterior, medial, lateral, superior, and inferior? Can oftentimes be confused between the different ones. And that's where it's really important to just kind of go and look through these questions along the way. So the correct answer here is A. That's what the majority of our people today got, although there were some mixed answers along the way. With D and with E. And so they give you a nice little table there and then the graphic of what the femoral hernia anatomy is. And in this case, the posterior boundary is going to be the Cooper's ligament along. The femoral vein forms the lateral boundary. The inguinal ligament forms the anterior boundary. The lacunar ligament's medial. And then we talked about Cooper's ligament forming the posterior. So again, kind of take a pause, think about where it is, think about the anatomy. For me, it's usually how I look at it laparoscopically, I find is the best way to think about it as opposed to how you look at it open. But again, these are just questions you need to know along the way. All right, question number 5. A 42-year-old obese female presents for elective incisional hernia repair. During surgery, it is noted that the hernia extends greater than 20 centimeters in the lateral dimension, and the decision to perform an anterior component separation is made. What abdominal wall layer is incised to perform this technique? A, the anterior rectus sheath, B, the internal oblique aponeurosis, C, the external oblique aponeurosis, D, the posterior rectus sheath, or E, the linea alba. So you really only need to look at the last 2 lines here. The first couple lines are just fluff, but the last 2 lines, the stem on the screen there is what's most important. Perfect. Let's look at the answer here. So correct. The right answer is C. The majority of you got that right, so 70%. External oblique aponeurosis. So there's different kinds of component separation techniques that are performed. They here specifically talk about an anterior component separation. If you kind of look, Dr. Awad, if you scroll down a little bit on the right, we can kind of follow the different steps along the way of the release that they're talking about. So step 1 there shows you have to create the subcutaneous flaps, and you actually take that out lateral, ideally, to your linea semilunaris. And then you're going to release the external oblique aponeurosis, and just the external oblique aponeurosis that you see there. And that allows you to release the components to the midline while separating the lateral tension from the external oblique. In step 3, they show where some people will combine that with a retrorectus dissection as well, or opening up the posterior rectus sheath. That isn't necessarily always has to be included. The other component separation, for the sake of talking about it real quick during this question, would be a posterior component separation, or what a lot of people call a TAR, a transversus abdominis release. That would be a posterior component separation, but they specifically tell you the anterior component separation. And so the correct answer here is C, external oblique aponeurosis. All right, moving on to question 6. When repairing an indirect inguinal hernia, where is the most common location for the hernia sac? Again, anatomy questions, just kind of have to think about it. A, superficial to the cremaster muscle and anterior and superior to the spermatic cord structures. B, deep to the cremaster muscles and anterior and superior to the spermatic cord structures. C, deep to the cremaster muscles and posterior and superior to the spermatic cord structures. D, superficial to the cremaster muscles and anterior and inferior to the spermatic cord structures, or E, deep to the cremaster muscles and posterior and inferior to the spermatic cord structures. So I think, from a test taking thing here, you got to break it down. Let's think about where it would live relative to the cremaster muscles and then where it would live relative to the spermatic cord structures, and then combine those two together to kind of get you into the right answer along the way. Because otherwise they just kind of run through all those different scenarios in your head. So where is it relative to the spermatic cord structures? Where is it relative to the cremaster muscles? We'll give 2 more minutes here. I think we still got a couple more people answering. All right. So actually, the group here performed pretty similarly to the way people have in TrueLearn. So we can see about 48% of people on TrueLearn got this correct. And about 44% of our group tonight got this correct. Again, anatomy questions, just have to sort of think about it. So the indirect inguinal hernia sacs are most commonly located deep to the cremaster muscles and anterior and superior to the spermatic cord structures. And so as you kind of, again, break it down from one section to the other, it'll line you up into where this question is going to come together. All right. Question 7. A 35-year-old man with a BMI of 23 seeks repair of an asymptomatic inguinal hernia. The hernia size is 3.5 centimeters. We can see a laparoscopic view of the hernia here. In which area must care be taken to prevent postoperative pain when stapling or tacking the mesh in place? So they're asking you anatomy questions for a minimally invasive inguinal hernia repair. The options for answers are A, the area formed by the inferior epigastric vessels laterally and iliopubic tract inferiorly. B, the area formed by the spermatic vessels medial in the iliopubic tract laterally and superiorly. C, the area formed by the inferior epigastric vessels medially and by the iliopubic tract inferior laterally. Or D, the area formed by the vas deferens medial and the spermatic vessels laterally. So they're going to ask you, which area is this? I think most of us know the names of these, triangles that we're talking about here, but they really want to know is what the anatomy that makes up that triangle. So as these answers are kind of filling in before we go on, again, the different triangles we talk about, triangle of pain, which is the one they specifically talk about. Postoperative pain, there's a triangle of doom. As the other one you'll hear mostly, the other one in the groin will be Hasselbeck's triangle, but we're talking about the triangle of pain here. So what anatomy breaks up the triangle of pain? All right, I think we got a quorum of answers. Good. So they're talking about the triangle of pain. The correct answer for that is the area formed by the spermatic vessels medial and the iliopubic tract lateral and superior. So if you look at this picture here, we can see A kind of makes up the area of Hasselbeck's triangle. B is the area lateral to the inferior epigastric vessels, which makes up your triangle of pain. So that's where you don't want to tack. C is your triangle of doom. You can actually see the iliac vein kind of right behind the peritoneum there. The structure right behind C itself is going to be the vas deferens. The structure kind of going between B and C is going to be your testicular vessels. The structure between A and B going up towards the ceiling is going to be your inferior epigastric vessels. So a good way as you're tacking, if you're doing that for these hernia repairs, technically make sure you can palpate the tip of your tacker before you fire any of these tacks. That will help keep you out of the triangle of pain and minimize the risk for these pain symptoms after inguinal hernia repair. All right, question number 8. A patient presents to your clinic with intermittent abdominal pain. On examination, you identify an incisional hernia at a previous laparotomy incision. You're eventually able to reduce the hernia after some time. Which of the following scenarios best describes an indication for an elective ventral hernia repair? A non-reducible ventral hernia with persistent abdominal pain. B, a reducible ventral hernia with intermittent abdominal pain. C, a ventral hernia with overlying skin necrosis. D, a large ventral hernia with nausea and vomiting and no bowel movements, or E, a non-reducible ventral hernia with lactic acidosis. So again, the technical thing here is they say best, and that's what's bold and all capitalized. But the key word here, I think, is an elective ventral hernia repair. All right, let's see the answers. We are so close to a perfect score for the whole group. I don't think we've ever had a question with a perfect score. I'm going to chalk it up to 2 people hitting the wrong button along the way.
That might
The
have been
correct
me.
answer here is, or Dr. Awad.
Yeah.
The correct answer here is B. So again, the key thing here is reading the question slowly, and they want to talk about an elective ventral hernia repair. So this is somebody that you can schedule them electively, you can bring them back and fix it at that time. All the other questions along the way are people who more likely need a more urgent repair. Now, you can make the argument that question or answer A doesn't necessarily need an emergent repair, but it wants to know the best one for an elective repair. And in this question, that is B. All the other ones, especially C, D, and E, need a pretty urgent or emergent repair. A is somebody that probably needs to get taken care of sooner than later with their abdominal pain, even if they don't have signs of necrosis or ischemia. All right, question number 9. Which of the following is true with regard to the long-term outcomes after congenital diaphragmatic hernia repair? A, recurrent rates are low with patch repair. B, chronic pulmonary disease is seen in roughly 50% of the patients. C, laparoscopic repair is associated with a lower recurrence rate. D, neurodevelopmental delay is uncommon. Or E, left-sided diaphragmatic hernias have poor outcomes. Probably something, unless you work at a busy pediatric center, you may not see very often as far as what you take care of in clinical practice, but definitely something that is worth knowing about. And again, this is one of those true questions. Good. Let's show our answer here. So the correct answer is B. Again, so this is actually a pretty mixed outcome, similar to what we answered here is what we see the TrueLearn group performed. Congenital diaphragmatic hernia is associated with significant long-term pulmonary morbidity. That's most often because due to the fact the herniated contents are up there, the lungs don't develop adequately. And so that's the result there. The second most common choice was actually E, left-sided diaphragmatic hernias have poor outcomes. That's actually untrue. They actually have better outcomes because they're easier to get to. You're not fighting to get over the liver. You don't have some of the tension points that are there as you try to close it. And so left-sided repairs actually have a better outcome in comparison to right-sided repairs. But the correct answer here is B, high risk of chronic pulmonary disease as patients age. All right, I think we got a few more questions here. We'll try to finish up on time. A 42-year-old female is undergoing emergent splenectomy secondary to severe idiopathic thrombocytopenic purpura, or ITP, refractory to medical therapy. Which of the following is true regarding the anatomic considerations of a splenectomy? The size of the spleen determines the number of splenic artery branches entering the spleen. B, the gastrosplenic ligament contains the splenic vessels. C, the splenic artery always arises from the celiac trunk. D, care must be taken to avoid injury to the tail of pancreas contained within the gastrosplenic ligament. Or E, the most common anatomic variation is a short splenic trunk that is divided into 6 to 12 long branches entering in the spleen. So which of the following is true regarding anatomical considerations of splenectomy? All right.
Be a tie here.
I know it's a close one.
Mm.
All right, so the correct answer here is E. And actually, we had a pretty similar breakdown. We had a 40-40 split, 40% split between D and E. But the correct answer is here. So the most common anatomic variation of the splenic artery is a short trunk and 6 to 12 long branches entering into the spleen. They fool you a little bit with D. And the reason for that is it's 100% correct. We always talk about risking injury to the tail of the pancreas when doing splenectomy. So you see that and you're like, that's got to be the right answer. But where they lead you astray is that they talk about it's within the gastrosplenic ligament. And if you read, the tail of the pancreas actually is contained within the splenic vessels, within the splenorenal ligament, not the gastrosplenic ligament. So that's the key answer there. You're right. We worry about injury to the tail of the pancreas, but what the key word there is a gastrosplenic ligament as opposed to the splenorenal ligament, which is where the tail of the pancreas lives. So the correct answer here is E, or high variation of the short splenic trunk. Question number 11. A 55-year-old man with a history of splenectomy presents to the emergency department with fevers, chills, left upper quadrant abdominal pain. He reports that he was diagnosed with a respiratory tract infection 5 days ago by his primary care provider, for which he's been taking amoxicillin. On physical examination, he has a temperature of 102.2 or 39 degrees Celsius, a pulse rate of 120 beats per minute, and tenderness in the left upper quadrant. Laboratory study shows a white blood cell count of 18,000 with a left shift, and a gram stain of the respiratory droplet demonstrates gram-positive cocci. Which of the following is the most appropriate antibiotic regimen for this patient? IV ceftriaxone and vancomycin, B, oral ciprofloxacin and gentamicin, C, IV ampicillin, sulbactam, and vancomycin, D, IV ceftriaxone and azithromycin, or E, IV piperacillin, tazobactam, or zosyn, and levofloxacin. So they give you a lot of fluff to tell you got a sick guy with a gram-positive cocci infection who had a splenectomy. But what you need to do is take all that information, think about what we know about patients who have had splenectomies and their risk for post-splenectomy sepsis, and then figure out what antibiotics are best for this patient. And I think, perfect. So the correct answer here is A, IV ceftriaxone and vancomycin. So the most common pathogens that you see listed there is strep pneumo, Neisseria meningitis, or Haemophilus influenza. And so here they actually tell you he's got gram-positive cocci. So ceftriaxone and vancomycin is the most appropriate answer to treat this patient's gram-positive cocci. Again, so he's got post-splenectomy sepsis. You know the vaccinations that they're supposed to get. You use that to work back to the most likely organisms, and then how best to treat it from there.
And one more question.
Perfect. All right, a 45-year-old man with a BMI of 42 is being evaluated for ventral hernia repair. He's noticed a bulge along a previous midline incision that has slowly increased in size but denies any pain or changes in his bowel habits. He has a midline incisional hernia containing bowel that's easily reducible with a large fascial defect. His history is significant for morbid obesity, type 2 diabetes, and he's an active smoker. He's interested in surgical intervention but is concerned about hernia recurrence, as am I. What is most appropriate counseling for this patient regarding hernia management and reducing the risk for recurrence? A, the hernia should urgently be repaired because it contains bowel. B, smoking is a significant risk factor for recurrence and the patient should stop smoking 2 weeks prior to surgery. C, a BMI of less than 45 is adequate for hernia repair. D, a hemoglobin A1C level of 9 demonstrates glucose control at a level appropriate for hernia repair. Or E, wound infections doubles the risk of developing a hernia. So they kind of hit you with all the big things that we talk about in the world of hernia surgery and patient optimization: smoking, diabetes, obesity, and then how best to reduce the risk for recurrence. I think the other key factor that's not really brought up in this question, but just while the answering are trickling in, I think there's 2 key points where patient optimization is critical. Here they're asking about recurrence. The other one is the risk for wound morbidity in the short term. A lot of times those things actually line up very closely to each other. All right, so actually pretty similar breakdown on TrueLearn for way the group answered. So we had 60% answer the correct choice of E. B was the next most common thing, talking about smoking. And although we agree smoking is a risk factor for recurrence, they kind of fool you a little bit there by saying they should stop 2 weeks prior. The general consensus is patients should stop at least 4 weeks prior not 2 weeks prior for elective surgeries. And there's multiple studies that show that along the way. You know, he does have bowel in it, but in these situations, most people agree that optimization is worth it. As we heard about earlier, those risk factors for who needs an urgent or emergent operation. BMI is, in my opinion, a linear relationship. So there's not a specific number for where that risk drops off and all of a sudden the risk is 0. They list here a hemoglobin A1C less than 8. Most of us ideally get down in the 7 to 7.5s if that's possible. But again, there's lots of factors you have to take into consideration. But when you take everything in this question, the correct answer is E. Wound infection would double the risk of developing a hernia. Now everybody is an expert in treating hernias and spleens, and they have no excuses for the ABSITE to not get those all correct.
Dr. Blatnik, again, a tremendous run through, and just really impressed with your expertise every year. I wish I could just transplant your brain into mine when we have these webinars. Thank you again, and I'd love to introduce our next speaker. Truly a pleasure and an honor to welcome back Dr. Pat Sylla. Dr. Sylla led our society admirably last year as the immediate past president of SAGES. Dr. Sylla is at Mount Sinai. She is a professor of surgery and the system co-chair of the colon and rectal surgery group there. She has been a leader in minimally invasive surgery and the development of a number of treatment paradigms, including transanal total mesorectal incision. She's also a leader in sustainability in our surgical environments and how we can better save the world, and one of her major initiatives last year when she was president. So many milestones. So busy person, and it's a distinct honor to welcome her to lead us in the next session on colon and rectal surgery. Thank you, Dr. Sylla.
Well, my pleasure. I have to admit, I felt a few of the previous section questions, so I feel all of your pain. These were really tough. Hopefully, colorectal will be a little easier.
All right, bringing up your questions now. Okay.
Okay, let's just move this and close this. Okay, first question to kick off. A 55-year-old woman presents with a temperature of 38.5, which is 101.3, with an ileus, diffuse abdominal pain following a sigmoid resection with primary anastomosis for recurrent diverticulitis. She is currently post-op day 4 from a resection. She gets a CT scan of the abdomen and pelvis, which shows a right lower quadrant fluid collection. Pay attention to the details. Which of the following is an indication for open drainage of this abscess? A, localized peritonitis. B, a fever higher than 101. Ongoing gastrointestinal spillage into the peritoneal cavity. D, single non-loculated abscess, or a visceral abscess. So here it's really reading the question very carefully, making sure you noted that it is a right lower quadrant when this patient had a sigmoid resection. So that's odd. You have to pick up on that right away. And then, of course, we know open drainage is rare. So what would really drive you in this day and age of IR interventions being so common? What would drive you to open this patient up and do an open drainage, which is pretty rare? I like what I see, and I see what I like. Yes, very nice. 81% of you, very close to the true learners' answers. So this is key. Most of the time you can drain an abscess like this. So the other questions are telling you localized peritonitis, single non-loculated abscess. These are things that you can probably drain with an IR drain. So the question is really, what would cause you to be worried enough about this patient? Essentially, you cannot control sepsis on this patient. Something is going on that you cannot control with the regular drain or antibiotics. Okay, and that tells you there's something terrible that happened on the other side of the abdomen. So probably an injury, anerotomy, or a colotomy, or something that is causing essentially a perforation and leakage of abdominal content, creating this abscess. So that would be the trigger to do an open drainage. The other indication for an open drainage would be obviously if an IR drain failed, or if you cannot access it with a drain. So, but this is not what you have in terms of options. So fever by itself is not strong enough of an indication to do an open drainage. And a visceral abscess is also something that's contained that also should be approachable or treatable with antibiotics. So yes, very good. Okay, second question. A 40-year-old man with no prior surgical history presents with abdominal pain, nausea, and vomiting for 2 days. He has not had bowel movements since the symptoms started. On examination, the physician also notes pigmented mucosal lesions on the patient's lips. See image below. Abdominal imaging demonstrates a target sign. What is the most likely cause of these patient obstructive symptoms? So they're giving you some very important clues. They want you to figure out what is the cause of this patient's abdominal obstruction. Target sign. And then they want to drive you to recognize a syndrome, right? This is clearly asking you what is a combination of target sign causing a bowel obstruction, and then with this pigmentation of the mucosal surface of the inside of the mouth. So hopefully, and they give you other ways to kind of figure it out, right? Because if you figure out what a target sign is, very good, you did it, 90%. That's incredible. Very, very good. So target sign tells you this is intussusception, right? And then you have this polyposis syndrome, Peutz-Jeghers syndrome, that has classic association of harmatous polyps that can cause intussusception in adults and in association with these mucosal pigmented lesions. Also ovarian tumors, breast cancers, and pancreatic tumors are common. So you have to recognize it. And if you look at the answers, if you could not remember, so if you have a lapse and you cannot figure it out, a Meckel diverticulum does not cause intussusception typically in adults. In children, yes, but not in adults. So that's one way you rule that out. Adhesions do not cause a target sign, so you would have ruled that out. And Pyer patches also is not associated with intussusception commonly. So that would help you rule that out and get to the right answer that way. Excellent job. Next question. A 72-year-old man with type 2 diabetes complicated by peripheral neuropathy is found to have rectal cancer on colonoscopy, undergoes a low anterior resection with anastomosis. He recovers well, and his final pathology demonstrates a well-differentiated upper rectal adenocarcinoma with a 1 millimeter invasion into the mesorectum without lymphovascular or nodal involvement and negative margins. Which of the following is the most appropriate management of this patient? This is a tough one. There's going to be several questions on the management of colon and rectal cancer, which I think is really important. And there's definitely been a lot of changes, but this one is a classic. But they're pointing you to a particular decision. And this is important to note. They mentioned the patient has severe peripheral neuropathy. That's an important consideration. And they're telling you have to be able to recognize a stage. So you have to figure out what a stage of this rectal cancer is in a 72-year-old frail patient, right? So you have to figure it out. They tell you it's upper rectal, well-differentiated, 1 millimeter invasion to the mesorectum, which makes it a T3. That's important to recognize that. Okay, so it's beyond the wall of the rectum. It's invading into the mesorectum. So it's a T3, but it's only 1 millimeter invasion. Okay, so that's not through and through the mesorectum. So it's early T3. Nodal involvement, no. So T3 and 0. You figured it out. Good. And so that's stage 2 rectal cancer with good features, right? There's no high-risk features here. So they're putting out a couple of really important things. And you look at the answer. So the question is, what do you do with a stage 2, completely resected, good risk rectal cancer? And this is where it gets tricky because they give you 3 options of observation. So essentially no further treatment. That's a hint. And they give you an option for proceeding with chemotherapy using oxaliplatin, which you should know causes the #1 complication of oxaliplatin-based chemotherapy is severe neuropathy. So that's something you need to know. And they give you the option of more oxaliplatin, this time combined with chemoradiation. So even more chemotherapy with radiation. And this is tricky because you have to think of stage 2 rectal cancer. Traditionally, we do recommend adjuvant therapy if it was not given in a preoperative setting. But in a very good risk stage 2 rectal cancer like this one, with no high-risk features, it is absolutely reasonable, according to NCCN guideline, to proceed with just observation because it was completely resected.
We have your NCCN guidelines slides if you'd like as well.
Oh yeah, so if you want to show that first slide, I think it's important because the NCCN guideline recommendations are changing. This is updated as of April. If you see a T3 N0 low risk rectal cancer, you have the choice. Either you do the resection and you observe, or you go and treat it like other more traditional T3 and 0 management, which is neoadjuvant therapy. And usually you treat them before surgery, so you give neoadjuvant therapy. You can skip the others. It's quite all right. I think I just want to make sure that you did. And so 51% is, I mean, I could totally get it. It's a little bit confusing, but here it's really asking you about how you surveil those patients. So when you figure it out, stay away from chemotherapy on the patient. Now, how you surveil them has to do with surveillance protocols for NCCN guideline. So you picked the observation, history, and physical every 3 to 6 months. Yes, colonoscopy at least 1 year later. And then if it's negative, you can push them to 3 years. But a CT scan is every 6 to 12 months. So it's really important to just know it would not be acceptable to delay colonoscopy by 3 years. It would not be acceptable to do a PET CT. It's not recommendation. The recommendation is to do a CT scan. You do not need a PET CT for surveillance of colon or rectal cancer. So this is really understanding the NCCN guideline. Okay, next question. A 76-year-old woman presents with a 1-month history of severe intractable anal pruritus. Physical examination shows an erythematous eczematoid rash around the anus. There is no tenderness or induration or ulceration evident, and there is no inguinal lymphadenopathy seen on examination. What is the most likely diagnosis? So you have very important pertinent positives and very important pertinent negative. I thought the picture came with the question. I didn't realize the picture came with the answer.
Yes.
This is one of those classic ones. This is a very common question on the app site. We also get it on the colorectal boards. It's rare, but you have to be able to separate that from other lesions that we see commonly, especially associated with STDs. And STDs is very common in the general population, so you have to be able to recognize it. Very good. I think people recognize exactly. So even with you, ideally you'd get the picture, but if you don't, think about Paget. Paget is definitely one of the favorites questions for the app site. Paget cells in a dermis that causes classic, very itchy, red, angry erythematous lesion. It's usually associated with another underlying cancer. So you actually have to work them out for possible SCC or adenocarcinoma. So it's not squamous cell cancer. Squamous cell usually presents as an ulcerated lesion that is very painful and seeping, usually at the anal verge or anal margin. Condyloma lata is secondary stage syphilis. That's usually a wet papule associated with lymphadenopathy. Condyloma acuminata, that's your typical warts. That has a very specific look. You know, the warts, the typical warts that look like cauliflower lesions, and they don't usually cause pain and have lymphadenopathy. And then you have lymphogranuloma venereum, which is also a very common question. LGV, which is chlamydia trachomatis, and that one also has a significant lymphadenopathy associated with it, and it's those ulcerated perianal lesions. So yes, you have to recognize Paget disease from the description. Okay, good job. Which of the following most likely describes a pathology associated with anorectal abscesses and the exciting event believed to be their etiology? You just have to understand where anorectal abscesses, the most common cryptoglandular anorectal abscesses come from. A small skin tear at the dentate line that occurred during straining due to constipation or hard stool. B, the small mucin secreting crypts get blocked, causing localized inflammation that eventually leads to abscess formation. C, hair follicles surrounding the anus get folliculitis and bacteria in stool allow it to become superinfected. D, they are sporadic and no one knows why they form. Or E, anal receptive intercourse. Which, by the way, is a very common question by patients. They will ask, did I cause this to myself? And this is something you really have to tell your patients. There's nothing you did that caused the abscess. And why is that? Because they result from, exactly, good job. It's those crypts in the anal canal at the dentate line that become blocked off, essentially, and that leads to superinfection from other bacteria in that area. So very, very good job, 94%, excellent. Okay, next question. Which of the following is an indication for a formal bowel resection after identification of a polyp on routine colonoscopy? This is a very important question. We discuss this kind of cases every week at our tumor boards in colorectal surgery. So What is it in the polyp that would trigger a formal resection? A, 3 millimeter margin. B, lymphovascular invasion. C, the finding of a serrated polyp. D, the finding of high-grade dysplasia. Or E, it's pedunculated. This is fantastic. Very good. I mean, I don't even know what to say. Good job. You have no proof it's a cancer. Okay, but you have to assume it is if you're recommending a formal resection. The serrated polyp in and of itself is not sufficient to warrant that. It's a higher risk for subsequent development of colorectal cancer, but it is not cancer. Same thing with high-grade dysplasia. Very good. Pedunculated has nothing to do with this. And a negative margin doesn't warrant any intervention. So yes, it is a finding of most likely an early or deeper adenocarcinoma invasive lesion. Lymphovascular invasion is high-risk feature that would prompt the need for a radical resection with a proper lymph node harvest. Excellent. Okay, next. During routine colonoscopy, a patient is found to have a tumor in a descending colon. The patient has a left hemicolectomy performed. The pathology report notes that the tumor is invading into the subserosa with 10 negative lymph nodes and a negative margin at 5 centimeters. Which of the following is most accurate concerning this patient? Okay, so there's very important description. And again, make sure you know how to stage this. They tell you exactly how to stage this. Okay, so A, the patient will need further surgery. He should be scheduled for a colonoscopy in 6 weeks. C, the patient may benefit from adjuvant chemotherapy. D, an oncologic resection was performed. And E, CEA level should be checked every 3 years. You already know that's wrong, right? Because you saw the NCCN guidelines. 3 years CEA levels is not going to cut it for surveillance. But very important. So where are we? This is really pointing out to adequacy of a radical resection for cancer. So what stage was this? Remember? So you can figure out this was a T3. You'll get it. Why subserosa T3, 10 negative nodes, so presumably a T3N0, so presumably a stage 2 colon cancer, not rectal, colon. Okay, so as we talked about, just like for rectal, you might be able to just observe that patient, but only if this was a good risk tumor, right? The problem in this case, even though the patient had negative margins, the problem in this case is that there were 10 lymph nodes, which means that it's not an adequate lymph node harvest, which means that the surgeon, unfortunately, did not get to the base of the mesentery, probably did not take the base of the IMA, and had essentially was too close on the mesenteric margin. So 10 negative nodes is a high risk for potential tumor progression. So in this patient, yes, the patient may benefit from adjuvant chemotherapy. So you're literally giving chemotherapy to compensate for is a inadequate radical resection, oncologic resection. Other risk factors, perforation, obstruction, or other very negative or high risk features that you would consider giving adjuvant therapy for a stage 2. Otherwise, stage 2, adequately resected, would not otherwise warrant chemotherapy. So very good. 62% of you got it. Very good. An 85-year-old female with severe COPD, type 2 diabetes, osteoarthritis, gout, CHF, and moderate AS is admitted to the medical ICU with pneumonia. On hospital day 6, she complains of abdominal distension, nausea, vomiting. Further workup reveals a colonic pseudo-obstruction. IV neostigmine and colonoscopic decompression are unsuccessful. Which of the following is the best step in treatment? Well, this is classic case scenario, classic consult on a Friday night. Okay, case answer A, tube cecostomy. B, loop ileostomy and antegrade enemas. C is a total abdominal colectomy. D, comfort measures only. And E, Hartmann's procedure. The patient is full code. Okay, they always are. Okay, this is a tough one. I like it very much because this is really a real scenario you're going to get called for, guaranteed. Okay, so you think about Ogilvy syndrome, obviously, you know, colonic pseudo-obstruction, same thing. All the risk factors, she has all of them. So you start from least invasive to most invasive, right? Stop narcotics, try to ambulate them, which I'm sure she couldn't do that. And then you step it up. She already got IV neostigmine, and she got colonic decompression, which didn't work. So what is the risk now in the patient who has ongoing problems, distension, is perforation and ischemia, right? So you have to do something. So what is going to work? Did we close the poll yet? Oh, we are all over the place.
A mix.
So just like the true learners. So this is, we all feel your pain. So the majority of you said C, total abdominal colectomy. Yes. So in reality, a total abdominal colectomy or a Hartmann's procedure, essentially to remove the colon and avoid a perforation or ischemia, would be the right answer in the right patient. Unfortunately, this is a very sick patient. What they're hinting at is that she's really sick. So can you do something that would not be associated with a 30 or 50% risk of death, is what they're trying to tell you. Is there anything else you can do? A loop ileostomy wouldn't work because you may not be able to decompress the colon, and enemas are not going to help. Comfort measure is out of the question. So he leaves tube cecostomy, which is not very sexy. We don't like tube cecostomies very much because they fall out all the time and they can come out and cause a leak. But in this particular case, you're really doing a semi-palliative procedure on this patient. You just want to avert a major emergency. So that's why a tube cecostomy is the choice here. That's the reason. But you were right. A total colectomy or Hartmann's procedure or a transverse loop colostomy would have solved the problem. But she is just too unstable, too frail for surgery. Okay. Next, a 50-year-old man undergoes a screening colonoscopy. A total of 3 polyps are identified, 2 of which are hyperplastic, each of which is less than 0.5 centimeter located in the ascending colon, and 1 is a traditional serrated polyp that measures 1.2 centimeter located in the sigmoid colon. A biopsy performed shows no evidence of malignancy in any of these 3 polyps. Which of the following is the next best step in the management of this patient? Okay, this one is going to be fun, I can tell. They love questions on polyps. You have to really be able to recognize polyposis syndrome, high-risk polyps, and how you are going to manage those patients who do not have a family history of colorectal cancer or colonic polyposis. What are the recommendations? Oh, you guys are killing it. Exactly. So you got the hint. This is only 3 polyps. That's not enough to meet the threshold for polyposis syndrome. 2 of them are hyperplastic, which is really low risk because they're really small. But really the only one that you have to worry about is that serrated polyp, which is 1.2 centimeters, so that you have to know the threshold. Any serrated polyp that is more than 1 centimeter is considered to be high risk. So you're dealing with a single high risk lesion, a polyp that was removed. So what do you need to do to surveil the patient? Yes, exactly. So you want to follow the patient with a colonoscopy 3 years later. And aspirin is something you need to know about. It is really considered to help potentially progression of those lesions. So that's the one thing to kind of keep in the back of your mind, is the addition of a baby aspirin, low dose aspirin for prophylaxis. But this table, if you don't have it, is fantastic. The table on the summary is really well summarized. The different risk factors and the findings for polyposis that would warrant surveillance and intervention. Good job, guys. Okay, a 54-year-old woman with a history of Crohn's disease has an EC fistula, has been on TPN for several weeks. She begins to develop a skin rash and has noticed that her hair has been falling out. Which of the following is the patient's most likely deficient in? So I got this one wrong because I haven't reviewed this in a while, but this is absolute classic upside. You just have to know, just like the deficiency from gastric bypass, you just have to know what the most common deficiencies are and what their symptoms, how they present, what the classic symptoms are. So you just have to memorize this one, guys. Hate to tell you. But this is pathognomonic. So the finding of hair falling out and skin rash is, yes, it is zinc. Very good job. And there's a nice table here that reminds you what the other elements, deficiencies, symptoms, or presentation will be. So yeah, this is pure memorization exercise. Okay, 40-year-old man presents to the office after completing chemoradiation for a 3-centimeter squamous cell cancer, so what we call SCC of the anal canal, about 8 weeks ago. On digital rectal examination, the physician is able to palpate a hard, irregular mass. Through it is smaller than pre-treatment, approximately 1 centimeter. There is no lymphadenopathy on examination. What is the most appropriate next step in management? Okay, so 2 months after completion of chemoradiation, and there's clear reduction in size of the lesion. So A, continuous surveillance. B, adjuvant chemotherapy. C, you biopsy the lesion. D, you do a salvage APR. Or E, you do a sphincter-sparing low anterior resection. I really hope we get a 90% on this one, because they give you a lot of really great cues, right? You can already rule out some of the crazy ones. Biopsy the lesion, why? Why would you do that? You already know it's anal cell cancer. Sphincter sparing low anterior resection is not possible with anal cancer. That's just not possible. Okay, more adjuvant chemotherapy after chemoradiation makes no sense. So you're down to 2 really good options. One is much better than the other. Continuous surveillance or salvage, which are the 2 you picked. Okay, so let's talk about why not a salvage APR. So the patient is responding. The key is the patient is responding. So how long are you gonna wait to decide whether or not the patient has a chance to completely respond? Because you know in anal cancer, the Niagara protocol, chemoradiation with mitomycin C, results in over 90% response. The tumor would disappear. We almost never do APRs anymore. So, but 8 weeks is not long enough, 2 months. So they're responding, which is really good. They're not progressing, they're responding. So it's definitely the case where you want to continue monitoring. And how long do you monitor them for? The magic word is 6 months. We usually wait 6 months of reassessing the anal cell cancer treated with Niagara protocol to see if they achieve a complete response. Okay, an APR would be premature because the patient is responding. You have to give it more time. You just have to give it more time. Okay. So good job. This was tough, but now you'll remember that. Okay, 32-year-old man with a history of UC for 1 year, has frequent fecal urgency, he's been on steroids and has exhausted other immunosuppressive therapy. He agrees to undergo an elective total proctocolectomy with IPAA. So you know that. That's a subtotal colectomy with IPAA. After removal of the colon and rectum, it is noted that the pouch, the J pouch, is under tension when brought down to the pelvis. What maneuver can be performed to create a tension-free anastomosis? This is a very technical question. A, you ligate the SMA. I love this. B, you ligate the IMA. C, you do a superficial incision of the mesentery along the course of the SMA. D, you do a superficial incision of the mesentery along the course of the IMA. Or E, you mobilize a posterior duodenum. And I know many of you have not done or been in the OR to watch these procedures. So I know that's not really fair. You just have to kind of think of the strategies that we use in the OR to try to lengthen the pouch, to reach down all the way down to the pelvic floor, to the anus, which is really tricky, and especially in our obese patients. So it's a tough one. I get it. You just have to memorize it until you get to the OR to see us struggle with this.
But
But
responses on this
yeah.
one, and we have
You
a
definitely
slide.
don't want to like the SMA, so I think they got that.
Yeah.
You don't want to like the IMA because the IMA is already gone, right? Right? You did a subtotal colectomy, so essentially the IMA is a stump. You've already come across the IMA at some point. So now it comes down to these incisions, which is called relaxing incisions. So it's actually it's really quite helpful. So yes, and you have 2 different options. Either you mobilize the mesentery by making these relaxing incisions over the course of the SMA or the IMA. Again, the IMA has nothing to do with this. So over the course of the SMA, just like this, it's like this step ladder type incisions that we make on the front and the back of the mesentery to just loosen the mesentery up, and it just gives you that extra reach. It is very helpful, and we have other maneuvers, but they're not listed here. So mobilization of the posterior duodenum is not very helpful. What you want to see, as you see in the picture, you want to get really close to the SMA, essentially. You want to mobilize the root of the mesentery all the way to as close to the SMA as possible. And if you haven't divided the ileocolic, you want to divide it as high up as possible off the SMA. Again, it gives you more length and more flexibility to reach down. And these are the critical maneuvers to use. Okay.
All
Fantastic.
right. Yes, phenomenal. And welcome back, Dr. Haskins, to introduce our speaker. Dr. Sylla, thank you so much. That was phenomenal as always. Truly an honor to have you on our panel.
All right, guys, and closing us out is not but last least Dr. Deal. She is an MIS surgeon at Virginia Mason in Seattle, Washington, where she is also the associate program director, as well as the curriculum coordinator. She gave us the sort of initial contact for TrueLearn, so thank you for that, Dr. Deal. This has been a great sort of collaboration and partnership with TrueLearn for the past 2 years. And she is going to be talking about the small intestine, biliary disease, and flexible endoscopy topics.
All right. Thanks everyone for having me. Hopefully everyone's still awake and excited to talk about some of my favorite topics. So we'll dive right in since I'm the closer. So we have a 42-year-old man with a BMI of 32 who presents to the emergency department with scleral icterus and acute colicky abdominal pain. He previously underwent bariatric surgery with Roux-en-Y gastric bypass, and laboratory results are notable for an increased total bilirubin and alkaline phosphatase and a normal prothrombin time in INR. Ultrasound demonstrates an inflamed gallbladder with a dilated common bile duct to 8 millimeters, and he's taken to the OR for a cholecystectomy. On an intraoperative cholangiogram, a 5 millimeter common bile duct filling defect is noted. There is no extensive inflammation around the hilum of the liver. What is the next step in management? A, laparoscopic transcystic common bile duct exploration. B, postoperative ERCP, just let our GI colleagues deal with it. Placing a common bile duct stent, transductal common bile duct exploration, laser-assisted bile duct exploration by laparoendoscopy. Let's see what our poll shows.
Coming up here shortly. There we go.
All right. Very, very good. It looks like you guys are, we've got a few takers for D, a couple interested parties. So one of the key things with this is, really taking back the bile duct. That's what we care about as surgeons. And I'd strongly encourage all of you to look at the SAGES Safe Chole platform. But in general, laparoscopic transcystic common bile duct exploration, which is a little bit of, being careful to look at which wording they're using, transductal versus transcystic, is important and a critical skill set of general surgeons, because you can often save the patient an additional procedure and do everything right there during the operation. And with this bile duct size and the dilation present and without a lot of inflammation, it's a really safe and technically feasible procedure to do. So A, of course, is the answer. I do really like some of the explanations in this particular question set that goes over some of the other approaches that we do use when transcystic is not possible. So being familiar with when to do a postoperative ERCP versus a transductal is really important. And we can go on to the next question. All right, we have a 55-year-old man with a history of jaundice who's found to have a pancreatic head mass on a CT scan that is concerning for adenocarcinoma. The patient likely requires neoadjuvant chemotherapy because the mass is determined to be borderline resectable, and he is scheduled to undergo biopsy. Which of the following is the best way to obtain a tissue biopsy of this mass? A, endoscopic ultrasound fine needle aspiration with radial echo endoscope, endoscopic ultrasound fine needle aspiration with curvilinear echo endoscope, ERCP with duodenoscope, CT guided fine needle aspiration, or gastroscopy. So a lot of great choices on here, but the critical piece is understanding which approach and which type of endoscope to use. So I can already see you guys weighing in on the A-B discussion. And they try to, this is one of those nitpicky things where you really need to think, do I need curvilinear or radial to be able to see the object that I want to sample? So I think we can go to the explanation. Most of you have weighed in. Very good. Most of you got it. So it does need to be a curvilinear echo endoscope in this case. Radial is more helpful for looking at variations in tissue depth, and in a circular structure, it can be really helpful. Whereas if you're looking specifically at the pancreas, which is a more flat structure, you need that curvilinear probe to be able to see that depth. And it's also important to know when you actually need an ultrasound with FNA. So these indications in this table are really helpful to kind of lock away for future questions on different topics. But EOS with FNA is a great skill set for identifying and treating with tissue diagnosis. And if you ever have looked at some of these pictures, it is helpful to just Google a radial echo endoscope and a curvilinear echo endoscope image, so that you can get that in your brain, because some of these question stems that I've seen will actually include the image, and then you have to figure out which approach is appropriate. All right, we have a 64-year-old woman with a history of diabetes, coronary artery disease, and appendectomy who presents to the hospital with altered mental status. On arrival, the patient's noted to be febrile with a blood pressure of 80/50, so she's hypotensive. Physical exam demonstrates right upper quadrant pain and jaundice. She's diagnosed with ascending cholangitis. What is the best initial step in the management of this patient? Endoscopic retrograde cholangiopancreatography with sphincterotomy, resuscitation and initiation of Zosyn, emergent endoscopic, well, ERCP with stent placement, resuscitation and initiation of ceftriaxone, or MRCP. So a lot of great choices here, but really the key point in this question sim for just kind of that question taking strategy wise is what is the best initial step. So there might be some other things on here that we would consider doing and would be next steps, but the critical aspect is you have to still resuscitate the patient and initiate Zosyn. That's really, you know, just like with trauma, with ABCs, with sepsis, we have to resuscitate and start antibiotics. That matters with all of these question stems as well. They have some really nice explanations here on biliary calculi being the most common cause of cholangitis. And the question stem very nicely laid out a patient with Raynaud's pentad. And that's just a great question to ask our medical students and our interns on the team, one of our favorites. So yeah, you can see Dr. Awad's highlighting that there. That's a really classic question for general surgery and a wonderful one to ask of our trainees. A couple other, let's see here. Oh, that's okay. We can go ahead. We are short on time, so I'll be succinct.
Okay.
We can go. Okay. All right. We have a 69-year-old male who presents to the emergency department with a 3-day history of worsening abdominal pain, nausea, and vomiting. The patient reports that the pain has initially been in the right upper quadrant over the last 24 hours, but now the pain is diffuse and more severe. He has not passed gas nor had a bowel movement since yesterday. Patient is febrile, normotensive, but tachycardic. Laboratory workup shows leukocytosis. Abdominal X-ray reveals multiple air fluid levels, a round shadow in the distal small bowel, and air in the biliary tree. Which of the following is correct regarding the treatment of this patient? A, the risk of recurrent gallstone ileus after surgery is about 30%. B, cholecystectomy along with removal of the stone does not affect the mortality from the surgery. Cholecystectomy and disconnecting the fistula should be done in all patients. Cholangitis and recurrence are common complications if cholecystectomy is done in the initial operation. Cholecystectomy should be done at the initial operation only in select patients. So I'll give you guys a few more minutes to chew on this one. And I'm also going to put a nice little link to a video of mine that highlights one of these cases if anyone's interested. Oops, that might have been a direct message. I'll send that to the whole group. And a link to the Sages Safe Chole program. So the final answer for this is E, cholecystectomy should be done at the initial operation only in select patients. This is a harder question, but most of you got it, so way to go, 74% versus the true learn 59%, so we're a little bit on top of it today. And really, the key is to figure out the best timing to take down this fistula and whether the patient can tolerate that additional step in the procedure versus just dealing with the obstruction. So this intense inflammation from the gallstone causes pressurization against the duodenum, and a fistula can develop there. And then that stone can then pass into the duodenum, travel through the bowel downstream, and cause a distal small bowel obstruction from the stone, which is a really interesting phenomenon called Bouveret syndrome. And this question really highlights that. But the safety profile is you shouldn't address that fistula unless the patient is truly in a good position to have that done and a safe surgical candidate. All right, which of the following conditions is an indication for prophylactic cholecystectomy? Asymptomatic gallstones with diabetes, bariatric surgery, porcelain gallbladder, 0.5 centimeter polyp, and 2 centimeter gallstone. These types of questions, when there's a size criteria of some kind, usually gets at a delineation, a cutoff where if it's under or over, you should know. And so they're never going to be right at that borderline. So I usually tell folks really make sure you know those distinct yes, no borders for size cutoffs for all tumor pathology, because it's really helpful for these tests. They really like to find those spots where they're going to put you in the no-go zone. Let's see what the answer is. I think most of you have weighed in. All right, this is great. So patients with a porcelain gallbladder should still have their gallbladder removed. It is an indication for cholecystectomy. You should definitely not be removing gallbladders prophylactically in bariatric surgery patients. That sometimes is still done, but it's not recommended. There isn't a benefit. And then for those size criteria, for polyps greater than 1 centimeter, those are the gallbladders that should come out, because there is a higher risk of malignancy being harbored within that polyp if it's over 1 centimeter. So this little 0.5 centimeter polyp doesn't need to come out. It could be watched, and you could do a repeat ultrasound at an interval time. And then gallstones themselves, if you have a really large gallstone, it's got to be 3 centimeters or larger to indicate prophylactic cholecystectomy, because there can be a higher risk of cancer in patients that have a really large gallstone. Okay. Now we have a 70-year-old woman who presents to the surgery clinic with abdominal pain and jaundice. Further workup shows gallbladder cancer. Which of the following is correct regarding the etiology and epidemiology of this condition? Gallbladder cancer occurs more frequently in men, and peak incidence is in the 3rd decade. 80% of gallbladder cancer cases are contained to the gallbladder at diagnosis. Native Americans have a lower risk of gallbladder cancer. Large gallstones carry a higher risk of gallbladder cancer. Choledochal cyst is not associated with an increased risk of this condition. So this question's a little funny, but still helpful, because our previous question actually helped us with this. And it is useful as you're going through these True Learn questions and really reading through these scenarios and explanations, that you'll learn a lot of information that will help you with future questions. So I usually recommend trying to read through those carefully and glean some of that, because you should know the answer. And you guys do. Look at that, 87%. You guys got it right. Large gallstones carry a higher risk of gallbladder cancer. And although this is an incredibly rare cancer, we do have a lot of information on what those risks are. And those big stones do have a 10-fold increased risk of cancer, which is why we recommend taking out the gallbladder. Really not a lot of other highlights from this explanation. What was the other thing I was going to say? Oh, the seventh decade of life. It does increase in the 7th decade of life, so you're more likely to see this in the elderly population versus younger patients that happen to have a really large stone. All right, we have a 45-year-old woman who presents with obstructive jaundice and cholelithiasis. The patient undergoes lap chole with intraoperative cholangiogram, which shows no flow of contrast to the duodenum. An MRCP followed by an ERCP is performed. What is the most likely diagnosis? Adenoma, lipoma, hamartoma, hemangioma, or distal common bile duct stone? And here's one of these great pictures where I was telling you to look at that B photo to figure out radial versus curvilinear, and understanding how to kind of identify and interpret what those images look like with endoscopic photos, because those are becoming more common on tests. And there's a really nice endoscopic photo on C to help you figure that out. And it's nice that they provide multiple photos, which is also increasing on the exam. Okay, let's see how you guys did. You did pretty good. Very nice. So it is A, adenoma. Small bowel adenomas are usually tubular, tubulovillous, or villous. They're predominantly found in the duodenum, and so this is a really common area to find one in the periampullary region, and only about 1 in 4 will harbor a malignancy. So it is important to resect these tumors, and most often that can be done endoscopically these days, because we have a lot of fantastic advanced GI endoscopists who can resect a small adenoma at the papilla or within the duodenum safely. In some cases for larger ones, or if the location is really challenging with the angle of the endoscope, it can be difficult. And then Oh, sometimes these patients can present with obstructive jaundice rather than in this scenario, they're giving you a standard lab chole patient that happens to have an interesting finding on their intraoperative cholangiogram. And this case would also highlight the importance of understanding and interpreting intraoperative cholangiogram and recognizing that it's not a stone that's causing that obstruction, but it's just not able to pass. So it's a narrowing at that site rather than an object. Okay, we can go on to the next one. A 50-year-old male presents to the emergency department with right lower quadrant pain, fever, and chills for the last 2 days. On physical exam, he is tender in the right lower quadrant without peritonitis. CT scan of the abdomen confirms acute appendicitis. He's taken to the operating room for lap appy, where an acutely inflamed appendix is removed, but incidentally, there's an outpouching along the antimesenteric border of the terminal ileum that's identified. Which of the following is true? Up to 20% of these will be symptomatic in the patient's lifetime. The most common presentation in this population is malignancy. The most common presentation in this population is bleeding. The diverticulum should be resected. No consistent data is available directing treatment of this pathology in asymptomatic adults. Let's see what you guys think. This is an interesting one. That additional finding in the operating room, not just your straightforward appendectomy, but surprise, something else to deal with. Ah, you guys are doing good. We've got some voters for A, C, D, E, all over the place. I like it for this one because it is a less discussed topic. So let's look at our explanation. So it is E, and this is hinting at Meckel's diverticulum, which is why they give you that question hint with antimesenteric border. And there's really no controlled data to support how we manage these. And it's the most common congenital anomaly that you might encounter in the operating room as an aside. And it occurs in about 2% of the population. So it's an anomaly, but not that anomalous. So you should encounter one at some point during your career. And in general, our current recommendations are to treat it as directed by the surgeons. There's really no consensus. So if you feel that there's a component of the Meckel's that's contributing to pathology and it should be resected, you can, but you don't have to, depending on the patient's presentation, especially if it's asymptomatic and it is just found at the time of the surgery. Now, patients presenting with symptoms is a different scenario, and that's partly why they give you this question stem of just happening to find it in the operation. Okay. All right. A patient is in the medical intensive care unit in septic shock secondary to pyelonephritis. Which of the following is the primary fuel source of small bowel enterocytes during this time period? So this is one of those fun GI physiology questions that we like to have on the ABSITE and the board exam. You've got to remember those details from long ago and keep them in the forefront of your brain, or at least jog through those little details before your test so that you're fresh and ready. And you guys are awesome. You're way smarter than us. All of us on this call were like, wait a minute, what was it again? But yes, it's glutamine. You guys are rocking it. About 60% of you got this right, actually. And usually the one that people confuse it with is short chain fatty acids. So those two are the ones that you should really delineate in your brain where they're at so that you remember. But glutamine is the most abundant amino acid in the human body, and the small bowel just thrive on it. So it's really important to make sure that patients get that in this case. The other component that you should remember is that short chain fatty acids are for the colonocytes. And that's the one that they typically get confused with. So short chain is for colon, glutamine, small bowel enterocytes, makes them super happy. Lots of new and interesting data is out there on arginine in the trauma population. Don't let that confuse you or get into your brain when you're thinking about enterocytes and colonocytes, because that's more of the physiologic component for nutrition. Okay. A patient has a small bowel resection for a lesion identified on CT scan. The pathology report indicates the lesion is consistent with metastatic disease. Which of the following is the most likely location of the primary tumor? So this is getting at those most common scenarios, lots of opportunity to refresh your memory on what is the most common XYZ for all of these different cancers and pathologies so that you are ready to answer these types of questions, which are a huge favorite on the board exam. All right. Let's see what the poll shows. All right. Oh, you guys got some Some top favorites with liver, skin. You can show the explanation now. All right, most of you got this right. It is skin. So the most likely metastatic disease is usually melanoma to the small bowel. That's the most likely scenario. So small bowel tumors on their own are relatively rare, and usually tumors that are found in the bowel are metastatic in origin, and they usually come from the skin. So really important to remember that the melanoma tumors love to go to the small bowel and often result in small bowel obstructions. So they can often present that way with an unknown primary. The liver is a very uncommon source of small bowel metastatic disease, and interestingly, and bone is also incredibly uncommon. All right, let's go on to our next one. A 55-year-old man with a long-standing history of poorly controlled Crohn's disease status post several small bowel resections is now TP independent with less than 100 centimeters of small bowel remaining. Which of the following interventions can help stimulate intestinal mucosal growth and improve fluid absorption? A. Octreotide. B. Ursodiol. C. Glucagon-like peptide 1, GLP-1, loperamide, or glucagon-like peptide 2, GLP-2. We are in the era of GLPs, so do not be confused by all of the GLPs that you are hearing about in the world. As a bariatric surgeon, this is near and dear to my heart. So questions like this are really key. Also, just a lot of rote memorization, but you've got to put in those minutes to remember them, and then try to relate it to something you know. Go ahead and show the explanation. All right. So this is going to be glucagon-like peptide 2. We had some takers for GLP-1. GLP-1s are the common injectable medications that we're using for medical weight loss these days. So that might be what you were thinking about and remembering in your brain. But GLP-2 is really it's also known as NREG, and what it does is it helps with short gut syndrome by stimulating growth of the small bowel lining so that the surface area of the small bowel that you do have left is maximally optimized. So if you remember all those wonderful photos of the villi within the small bowel, that medication's job is to stimulate and grow the villi so that that internal surface area within the remaining short gut is more likely to result in improved absorption of all of these minerals and fat-soluble vitamins as best as able. And octreotide, just to remind you, is the opposite effect. It's going to dry up your secretions considerably, and we use that for gastric hypersecretion and trying to slow down things like enterocutaneous fistula. Ursodiol is a medication that we use to treat biliary flow and improve biliary flow, whereas loperamide is our classic Imodium for slowing down ileostomy output and helping with diarrhea. So we can move on to the next one. We did it. This is our last question of the night, everybody. What a day. What a fantastic event. So here you have this wonderful photo to end with. It looks like someone who's ready to go eat a meal. A 55-year-old man presents with vague abdominal pain, intermittent facial flushing, and diarrhea. On workup, urinary 5-HIAA is elevated, and on CT scan of the abdomen and pelvis, he's found to have a 3-centimeter mass in the mid-small bowel and a 1-centimeter mass in the right lobe of the liver in segment 8, without hepatic vein or portal vein involvement. Somatostatin receptor dotatate scan confirms that only the mid-small bowel mass and liver mass are present. Push enteroscopy demonstrates the finding below. Biopsy of the mass confirms the diagnosis, and tumor histology shows that it is well differentiated. What is the best treatment plan? So they're asking you about treatment with the assumption that you will know what this is based on the question stem. A, resection of small bowel mass with underlying mesentery with anastomosis and ablation of mass in the liver. Resection of the small bowel mass with underlying mesentery with anastomosis and resection of the liver mass. Treatment with somatostatin analogs. Ablation of liver mass and treatment with somatostatin analogs, or resection of the liver mass alone. All right. Looks like we've got most of our pollers coming in. You guys are fantastic, rounding it out with a great response rate for this one. I think we can show our answer now. Wonderful. So B, resection of small bowel mass with underlying mesentery with anastomosis and resection, not ablation, of the liver mass is the correct answer. And treatment of carcinoid tumors of the small intestine is really based on the location and size, but primary tumors less than 1 centimeter without evidence of nodal mets can be resected in this fashion. If you have an isolated liver metastasis or a number of liver metastasis that would respond to debulking, as long as you get 90% of the disease, it's still considered a recommended approach for well-differentiated tumors because the microbiology of the tumor is appropriate to proceed with a more aggressive resection. So hepatic wedge of the isolated lesions as well as the primary lesion, which is the small bowel lesion, is appropriate. And oftentimes these can be identified on that double balloon enteroscopy, which is what they were referring to with the push enteroscopy. So that's just another name for it that we say colloquially, but really it's a double balloon enteroscopy. All right. Thanks everybody for your time tonight.
So I'd like to invite all of the faculty back on. Looks like everyone's on. Thank you again so much for your time, your expertise tonight, your fantastic teaching points and test taking strategies. No doubt this will help all of the participants as they venture on to take the ABSITE. Thank you to the participants for joining us this evening. And just a reminder that this is part 1 of a 2-part webinar series. So we will cover the remaining topics for ABSITE on Tuesday, January 14th in 2025, the new year. At the same time as it currently is, wherever you are in the United States or across the globe. I would just like to reiterate, if you're not yet a SAGES member, please join us. SAGES really is extremely inclusive. There's something for everyone in SAGES. We love this organization. And we look forward to hopefully seeing you again in January. Thank you, everyone, and have a great night.
Thank you.
Great job, guys.